Hello, hi. For those of you that don't know me, I'm Louise Newson, and I just thought I would try and cheer us all up and have us something to think about on this Sunday afternoon other than coronavirus. So I've been inundated with questions. I'm going to put my glasses on because I can't read what's coming up without them. I've had lots of questions before, so what I've done is I've grouped them together and I'm going to try and get through as much as possible. In an hour, I can't tell you everything I know about the menopause, but if you like this, then give me some feedback, and I'm quite happy to do regular sessions, and maybe we could group them to have different topics, so there's something for everyone in each session that I do. Just to introduce myself really, for most of you probably know already, I'm a GP, but I'm also a menopause specialist, which means I've had some advanced training with the British Menopause Society and the Faculty of Reproductive Sexual Health. I've also done a lot of hospital medicine, so I'm very interested in disease prevention, so I'm very interested in diseases such as diabetes, heart disease, dementia, long-term health conditions as well. And this is where the menopause comes in. So just to also let you know, I'm not sponsored by anyone, I'm not paid by anyone, I don't work with a drug company. I'm just doing this because I'm really passionate about women being able to have evidence-based, non-biased information. So just to get it out there, I'm doing this just in my own time because I want people to be able to be empowered, to have the right information to get the right help for them. So what I really wanted to do initially was just to tell you what the menopause is. So if you break down the word meno, it means menstrual, so our periods. Pause means stop. So it's actually when we've had a year without our periods. So for most women it's really hard to know because our periods maybe become less frequent, they become a bit irregular. So does this mean we're menopausal? Well, officially no, because you have to be a year since your last period. But for a lot of women, they experience menopausal symptoms before their periods stop. So this means that they're getting symptoms, but they're still having periods. So they are not menopausal, but they're actually perimenopausal. Peri is the medical term for around the time of. So a lot of women come and see me in my clinic or go and see their GP and they're saying, well, I'm having my periods, therefore you're not menopausal, which is true, but actually you can get help. So what happens with the menopause is that we have a finite number of eggs in our ovaries. We have our ovaries that produce our eggs, and associated with the eggs we have hormones. The most important hormone for females is estrogen, there's also progesterone, and there's also testosterone, which I'll talk about in detail in a bit. So when our eggs reduce, we have less hormones, and when we have less hormones, this has effects and symptoms all over our body. Now, with our hormones, we have cells that respond in our gynecological tract, so causing periods. And obviously our hormones are in tune with each other as we go through adolescence and we develop periods. But when they become less, they affect different cells all over our body because we have receptors that respond to cells all over our body. So this means that we have cells that respond to estrogen and also testosterone in our brains, in our muscles, in our joints, in our hearts, in our blood vessels. We also have them in our urinary tract, in our vaginas, we have them in our lungs, we have them in our bowels, we even have them in our eyes. And the reason it's important that you all know this is because without these hormones we can get symptoms all around our bodies, so in our eyes, in our bowels, in our bladders, in our brains, in our hearts. And so a lot of women develop quite different symptoms, and everyone's experiences of the menopause and perimenopause is quite different as well. So most people, men and women, when they think about the menopause, they think about flushes, they think about sweats, and these are called vasomotor symptoms, and this is because the regulatory, the thermoregulatory systems in our body is affected. But actually they're not the symptoms that affect people the worst, it's other symptoms. So other symptoms include symptoms such as joint pains, muscle aches, because like I say, estrogen gets into the joints and the muscles. Also in our brains, with low levels and fluctuating levels of hormones, people develop symptoms such as fatigue, memory problems, concentration problems, motivation problems, memory problems. Brain fog is really common because estrogen is so important for these processes that occur in our brains. And then also people can sometimes get headaches or worsening migraines. A lot of people feel they have a tightening sensation around their heads. And then people can get symptoms such as recurrent urinary tract infections because of the estrogen, the low estrogen that occurs in the bladder and also the urethra, the tube that we wee out of. Symptoms such as vaginal dryness or soreness can occur. And often women complain that it's uncomfortable having sex. But also I see a lot of women who find it hard to wear underclothes, they find it difficult to sit down. A lot of women tell me they don't cycle anymore or even wear a swimming costume because it's so uncomfortable. And then other symptoms that can occur, symptoms such as some people get bowel symptoms, so people get symptoms such as irritable bowel syndromes. I've already said it can affect our eyes, so some people get dry eyes. Some people get allergies, some people get sleep problems. Low libido is really common. The list goes on and on and on, and different websites will tell you there's a different number of symptoms, and actually there's so many symptoms. And the symptoms often come on very gradually, so it's sometimes very hard to know whether your symptoms are related to life or related to your perimenopause and menopause. And a lot of women, including myself, don't recognise these symptoms because they come on at times when we're busy. And it's very common that we feel anxious, that we feel worried, that we feel low in our mood, that our sleep's affected. So when all these symptoms occur, you just think it's life. And especially at the moment, with everything that's going on with coronavirus, we've got so much more anxiety. So it's very hard sometimes to tease out symptoms. So how do we diagnose the perimenopause and menopause? It's all very well saying we have all these symptoms, but what do we do? Can we go to a doctor and just have a simple blood test? Unfortunately not. It's not as easy as that. And actually blood tests are very misleading. And the reason being is that our hormones fluctuate all the time, especially when we're perimenopausal. And because of that, I could do a blood test on one of you one day and the next day and the day after, and then I'll get 3 different results. If they're abnormal, then it can be quite useful, but if they're normal, it doesn't help. So the guidelines are very clear, and so certainly in the UK we work out of the National Institute of Clinical Excellence, the NICE guidelines they're called. Also we have the British Menopause Society guidelines and the International Menopause Society guidelines. So worldwide doctors should be working out of them. They're very clear about the diagnosis. So if a woman is over 45 and her periods have stopped for more than a year, or her periods have changed either in frequency or nature, then she can, and she has symptoms, then she is menopausal. Even if she doesn't have symptoms, she's still menopausal if she hasn't had a period for over a year. If you are having periods that are irregular and have changed, and you're over 45 and you're experiencing symptoms, then you're perimenopausal and you do not need a blood test. The guidelines then say if you're between 40 and 45, then a blood test may be useful. I've actually found in clinical practice they don't really help because again there's so much fluctuation. And then we know that around 1 in 40 women in the UK have an early menopause, and this is defined as premature ovarian insufficiency, POI. It's a bit of a mouthful. But these women, it's recommended that they should have blood tests taken around 6 weeks apart. Now, those blood tests are FSH levels, which are follicle stimulating hormones, and this is a hormone that our brain produces. So if our level of estrogen that we produce from our ovaries is low, then we have an increase in this FSH hormone. However, it fluctuates a lot. So I have seen countless women in my clinic who have had normal FSH levels before. They're young women under the age of 40, yet they have so many symptoms. So often we still go on a clinical diagnosis. So if a woman is under 40, we often do other blood tests as well because it's very important to make the right diagnosis. And often an early menopause is associated with other conditions, other autoimmune diseases such as diabetes or thyroid conditions. So we often do other blood tests to make sure there's nothing else going on. Now, with the symptoms, we use in my clinic this, which I printed off from my website, which is a menopause symptom score. And if you look, I know it's going to be back to front because it's on my phone, but it's got various symptoms, and then they're graded from 0 not at all to 3 extremely, with a little comment box. And this is something called the green climacteric score, green with an E on the end. But if any of you go to my website, Menopause Doctor, and just put in questionnaire, then you'll come up with a questionnaire. And actually this is very useful. We do it on all our patients before we see women, and then going forwards to monitor their response to treatment if they have treatment. And it'd be really useful for any of you that are suffering to download this questionnaire, print it off, fill it out, show it to your doctor. And if your symptoms are occurring with your changing periods, then you've made the diagnosis yourself. Now, what about women who've had a hysterectomy? Or what about women who have a Mirena coil, for example, which is a coil that often leads to periods not happening? Or what about people that are on other contraceptives leading to not periods? Well, then it's harder, and you have to really think carefully about your symptoms. If women are over the age of 45 and experiencing these symptoms, the chances are that you are having some perimenopausal symptoms. Most of us will have symptoms in our late 40s for sure, but sometimes perimenopausal symptoms can go on, sometimes for a decade. And because they come on gradually, you just got to be really mindful. So the more that you read and the more that you understand about how important our hormones are, then the more aware you're going to be about your symptoms. So the menopause isn't just about symptoms though. A lot of people think, I'm going to have symptoms and then I'll get through it, I'll battle through it, and then I'll come out the other side and I'll be postmenopausal and my life will carry on again. And for some women that happens. Most women need, or well, research varies, but the average length of time of symptoms is 7 years. 7 years is a long time to have symptoms. But some women find that their symptoms change. So they start having flushy sweats, these improve, and then they might get anxiety symptoms or depressive symptoms, or often people then get symptoms related to vaginal dryness or recurrent urinary tract infections. So once we have low hormone levels, our hormone levels are always going to be low. So we need to think about the menopause as a long-term hormone deficiency. So we'll never get those hormones back unless we take them ourselves. And so because of this, it means that our body systems are exposed to very low levels of hormones. And this leads to potential problems. And this is where me as a physician is very interested in getting the treatment right for women. And so when our hormone levels are low after the menopause, we have an increased risk of conditions such as heart disease, diabetes, osteoporosis, osteoarthritis, type 2 diabetes, dementia. It's quite doom and gloom for menopausal women, but it's important that you know this so we can look at ways of reducing this risk of these conditions. If you think back to the Victorian times, our natural menopause was actually a little bit older, in our mid-50s, whereas now it's early 50s. But then the average life expectancy was about 57, 59, so we used to die quite soon after our menopause. Whereas thankfully now we live a lot longer. The average life expectancy in the UK is in the 80s. So most of us, hopefully, will be menopausal for about 30 years. And that means we won't have hormones in our body for about 30 years. And this is why the increased risk of these conditions needs to be thought of. So a lot of women will say, well, the menopause is just a natural process, I'm just going to get through it. And yes, of course the menopause is natural. It's not a condition, it's not a disease, but actually it can lead to diseases. A woman, for example, after the menopause is 5 times more likely to have a heart attack. We know from figures from the Royal Osteoporosis Society that 1 in 3 women have an osteoporotic hip fracture, and 1 in 2 women will develop osteoporosis. So this is really important when you think about our life expectancy and diseases that might occur. We also know that most of us as women will die from heart disease. So any ways that we can reduce this disease is really important. So this is why it's really important that we get our treatment right, because we're all different. We all have different experiences of our perimenopause and menopause, and therefore we should expect different treatments. We're allowed to have different treatments, and we need to be given the right information so we can make the right information for ourselves and make the right decision. So I've tried to group through a lot of questions that they've had, that I've received from you all, and there's a huge amount. Most of the questions have actually been about HRT, unsurprisingly. So what I'm going to do, if it's okay, is spend some time talking about HRT, and then I'll spend some time talking about alternatives to HRT, and then we'll just go through and see how the time goes, if that's okay. So HRT is 3 letters, hormone replacement therapy. That's all it is. Lots of people think it's one size fits all, and it's not, because I've already explained we're all different. We all have different hormones in our body, different amounts, and these vary with time as well. So I've already said the most important hormone is estrogen, and then we also produce progesterone, and we also produce testosterone as well. So estrogen is the hormone that affects us all around our bodies and is very important. So there are different ways of having estrogen. There's a tablet, there's a patch, or a gel are the 3 main ways of having estrogen. Some countries have a spray that goes through the skin. Traditionally, HRT always used to be tablets, and it used to be a combination of tablets of estrogen and a progesterone, and this has changed. So the estrogen as a tablet it used to be made from pregnant horses' urine, which is quite grim really thinking about it, but they used to get the urine from pregnant horses and then get the estrogens out of it and make it into a tablet. And this is where a lot of research actually has been done. Thankfully now we don't prescribe that, and certainly I don't prescribe it in my clinic. We tend to prescribe what's called body identical hormones, which means that it's the same structure as the hormones we produce ourselves, which thankfully is a lot more acceptable. They're derived from yams, the root vegetable, so no horse's urine has been involved in making the hormones that we prescribe. So having this as a tablet is okay. We used to give it a lot more as a tablet, but actually if you think, when you take a tablet, it has to be digested, it has to be metabolized, it has to be broken down, so it depends on what else you're eating, what your digestive system is like. But also, when you digest something, it has to go through the liver, and our livers produce our clotting factors. And so that means women who have tablet estrogen have a very small risk of clot. It's only a very small risk, it's about double, which sounds quite scary, but actually a double of a small risk is still a low risk. So for a lot of women who are fit, active, no history of any clot problems, who aren't overweight, absolutely fine, they can still often take the tablet estrogen. However, I've already said we often use estrogen as a patch or a gel, and the reason being is that you put it onto your skin, it goes straight through the skin into the bloodstream, so it gets where it needs to happen, but it also bypasses the liver, so there's no risk of clot. So certainly I've got some here that I can show you. This is a gel, the estrogen gel, which is a pump. So you literally, it's got, I can just show you actually if you want to see what it looks like. It's just a clear gel that gets rubbed in, and then this gets rubbed in either on the outside of the arms or the inside of the thighs. And the dose varies. A lot of people have asked, well, how do you know how much to use if you're just if you're not doing a blood test? Actually, we often, it is a bit of guesswork, but we often start with a lowish dose and then we review people and we use the symptom scoring, like I said before. So if someone's symptoms are improving but they're still having symptoms, especially flushes and sweats, then we often increase the dose. And the gel can be very flexible because people can change the dose. And a lot of women who are perimenopausal, so still having periods, often find they have days where they feel fantastic, they conquer the world, they feel brilliant, and other days where they just want to stay in and not go out, they feel terrible, they have worsening migraines, they feel really low in their mood, and that's often because the hormones are dipping. Classically, hormones dip just before the periods or around the time of the period. So if a woman, for example, is using 2 pumps of the gel each day, she might find that using a 3rd pump around the time of her periods, when these symptoms come worse, is really useful. So it can be quite flexible. And certainly as a doctor, I want to empower my patients so they're more in control. And the more control they have, the less they have to see me, which is obviously really good. In the UK, we also have these called Sandrina, which is a little sachet of gel. And you'll see the sachets are quite small, and if I push it up, there's only a very small amount of gel there. And this is equivalent to around 1.5 pumps of this gel. And so you'll see that the volume is slightly less. So if someone is on a lot of gel, these can be quite useful, or they find they're not absorbing it properly, then these can be useful as well. And then there are patches. There's quite a few. I've got some different ones here to show you. And the patches are usually very good for a lot of women. So I'll just open one and show you, but they usually stick usually below the waist, often sort of on the lower back or the bottom area, and they're quite thin, so you can see these are very thin, sticky plasters. They come as different sizes. So this is an average one. It's quite sticky, so it lasts for 3 or 4 days. So normally you change them twice a week, and people can swim, shower, exercise in them, so they're very good. Now, for those of you in the UK, you'll realise there's a shortage of these patches, which is an absolute nightmare, and it's a complete headache for us as menopause doctors. There's been all sorts of people writing, lots of journalists writing about why it's happened, whether it's Brexit or whether it's politics or what. I think actually a lot of it is due to increased demand, because more women are wanting the patches and the gels, and the drug companies have been very slow to respond to this increased demand, which is incredibly frustrating. Some of the patches are coming back in stock, so Everil is one of the patches which is coming in, but too slowly for my liking, but I think over the next few months that will change. I know a lot of you who have asked questions have been asking about what happens if your symptoms occur when you've changed patches, and this is often because the absorption is different. So each of these patches are made by different companies, so the adhesive, the sticky bit, is different, so therefore the way it's absorbed through the skin is different. So people often feel great on one type of patch, they change to a different one and it will say it's the same dose, the same type of estrogen, but they feel different. And if that's the case, it's often because it's not being absorbed properly. Now, some people say, well, can I put a sticking plaster over the top of the patches? If you're having to put a sticking plaster over the top, you're just not getting it properly, you're not absorbing it properly, so don't waste your time. You need to ask for an alternative patch or the gel. Some people find that one type of patch works brilliantly and another doesn't. So if you do have a choice, then I would certainly ask your doctor for another one. And the patches can be very useful. Certainly a lot of young women need higher doses of estrogen. And the way we prescribe estrogen is according to symptoms, especially the vasomotor symptoms, the flushes, sweats. When people get those symptoms, that's often related to low estrogen levels. And we know that there is a licensed amount that they say is maximum, but we often prescribe more than the licensed dose. And this isn't because it's dangerous, it's just some people need higher levels. Certainly younger women who have had an early menopause or premature ovarian insufficiency often find they need to use a lot higher doses than older people. And that's because their bodies are designed to have a higher amount of estrogen. And you can imagine if you're using the gel and you're using 8-10 pumps a day, you're soon going to run out of skin. And so often we use the patches, and we often recommend 1 or 2 patches together, which some doctors, nurses, and even some patients think that's dangerous, that's too much. But actually, if you think about a diabetic, for example, a patient with diabetes, often they have differing amounts of insulin, different requirements, or if any of you have thyroid, an underactive thyroid gland, you'll find that you'll have a different dose to some of your friends who have got an underactive thyroid gland, and it's just the way our bodies use it. I've often found with experience that women who are very fit, who are athletes, tend to metabolize the hormones more, so often need higher amounts. And this is where doing a blood test can be useful sometimes in the clinic. So sometimes what we do is we monitor the blood test of the estrogen level. It's called an estradiol blood test. And that's very useful when someone's on HRT and they're still getting symptoms. So if someone saw me in my clinic, for example, and they were using a couple of pumps of gel and they come back and they say, well, I feel a bit better, but I'm still getting symptoms such as night sweats or muscle joint pains, then I'll do their blood test, because it will give me an idea, firstly, if they're absorbing the gel, and to see roughly what their level is. Because if their level is quite high, then as a doctor, I'll be thinking, well, has there another reason for them to be getting these symptoms? Whereas if their level's low, then I know I can safely increase the dose, and it will reassure me as a doctor and reassure the women that it's quite safe to increase their dose. So although we don't do blood tests to diagnose the menopause usually, often we do blood tests in the clinic so that we can just monitor response to treatment. Some women start HRT and go, wow, I feel brilliant, all my symptoms have improved. And then after a few months they say, oh, I feel back to where I was before, the HRT is not working, what can I do? And often it's just because the body needs more. And so the dose can change quite a lot. Sometimes people can be stable for a few years and then need their dose changing. But generally younger women need a higher dose than older women. So this is the estrogen part. So estrogen is the bread and butter, if you like, for HRT. Most of us need estrogen, and certainly it's very unusual to not prescribe estrogen. If a woman has had a hysterectomy, then usually that estrogen is what she needs. She doesn't need a progesterone. The reason that women have a progesterone is to protect the lining of the womb, because if a woman just has estrogen, then there can be a build-up of the lining of the womb, which you don't want, because that can cause bleeding, it can cause some thickening of the lining of the womb, and very, very rarely it can cause cancer of the lining of the womb. So certainly as a doctor, I don't want to give something that's going to cause cancer. So the way we negate that effect on the lining of the womb is to give a type of progesterone. Now, there are different types of progesterone, and this is where it can get a bit confusing, because the synthetic progestogens, they're called, so the ones that are not body identical are called progestogens, and these just mean they're synthetic. They're made, I mean, everything is made obviously in a factory, but these are not the same structure as the ones that we produce ourselves. And so these are the types of progestogens that are in combination tablets, combination patches, things like norethistro, medroxyprogesterone acetate. They've been around for a long time, and they are associated with some risks, which I'll talk about in a minute. There is a body identical progesterone, which is called Utrogestan in the UK, or micronized progesterone, and this is the body identical one. So it's derived from the yam, the root vegetable. So the yams we have to be very grateful for. You can't eat yams to get your hormones, unfortunately. So the progesterone usually is taken as a capsule. Now, loads of people have asked me about progesterone. Now, we need to have progesterone to protect the lining of our womb, like I've said. There's different ways of taking it, and this all depends on whether you're having your periods or not. So, if you are perimenopausal, so that means you're still having your periods, but you've started to have symptoms that are having a negative impact on your life, and you're going to start HRT, then you want to take what's called sequential HRT or cyclical HRT, so it will still give you your periods. And so the way that you take this is you have 2 of the Utrogestan capsules together. You take 2 together at night time on an empty stomach for 2 out of 4 weeks. Now, they're actually licensed for days 15 to 26. We usually say 2 weeks out of 4 weeks because it's easier to remember. No one wants to be counting days. And often people's cycle length changes and varies. So if you have 2 weeks with just the estrogen, 2 weeks with the estrogen and the progesterone, and you just get into this pattern, and periods often then become lighter, they become more regular, a lot more manageable, and so that's usually what we recommend. If a woman is a year or nearly a year after her last period, so she's nearly or she is menopausal, then what we do is we say take one of the progesterone every evening, and then that way what the progesterone does is it stops the lining of the womb building up, so therefore there's nothing to shred, so therefore there's no bleeding. So if you take one every single night, the lining of the womb becomes very thin and it doesn't shred, so people don't get periods. And as a menopausal woman, the last thing you want is a period often. So it's a really good way of having the progesterone. It's actually licensed as days 1 to 25. I think a man must have decided how to license them, because actually, how can you have days counting your periods when you don't have periods? It doesn't make sense. So again, we usually just say take one every night, all the time, because it's just easier to remember. And then that makes it very simple. If a woman has been on the sequential HRT, where you have 2 weeks on, 2 weeks off, for around 6 to 12 months, and they're happy and it's happening quite nicely as with the periods, then you can change to take it as a continuous. So then you don't have periods, because what you don't want to do is keep having periods taking HRT. So even if a woman is young and wants to stop her periods after, say, 6 months of taking the sequential HRT, she can just change the progesterone, and then she just takes one at night. So it's very easy. There's some confusion because some people think you have to be 51 or you have to have taken HRT for 2 years before changing to the continuous HRT, but that's not true. It's better for the lining of the womb to have continuous progesterone. Now, the progesterone, the Utrogestan, this micronized progesterone, should be taken at night time. The reason being is that it's a slight sedative, which is quite nice for a lot of women, because poor sleep is a really, really common symptom of the menopause and perimenopause. And I didn't realise how common it was until I saw the hundreds, if not thousands, of women that I see in my clinic. So if you take it at night time, it can help sleep. It also should be taken on an empty stomach. And the reason they say that is because the absorption can actually increase if you have it on a full stomach. So it's not the end of the world. If you do shift work or you eat late at night, you can still have it. It's absolutely fine. Having too much progesterone is not a problem. Some women actually take more than one tablet. If they're still getting bleeding, we often recommend to take 2 tablets. And the micronized progesterone, like I say, is the safest one to take. Now, there are still some women, despite having the natural progesterone, get side effects. Side effects of all progestogens are symptoms such as spottiness, bloating, weight gain, breast tenderness, mood changes, sort of a bit PMT-like, and some people are very sensitive to those side effects. I think I've read different things, but it's about 10% of women, so it's quite a lot. 1 in 10 people are intolerant of the progestogens. If you're taking, for example, a combination tablet and you're getting these symptoms, or a combination patch, or anything with the synthetic progestogens in, then the first thing you need to do is ask for the micronized progesterone, which is a body identical progesterone, because there's less side effects with it. I like giving the estrogen and progesterone separately, because if a woman needs more estrogen, we can increase, and we don't always have to increase the progesterone. So that can be just the first step. Just ask for the micronized progesterone. Now, I know in Scotland it's not always available, which makes it difficult. Some of my patients in Scotland are still getting it by asking very firmly, but that can be difficult, or some people get it on a private prescription. However, even taking it like that, some people still get side effects to progesterone. So there are options, there's always choices. And this is why, if any of you are struggling, you really need to see a doctor who specialises in the menopause. Sadly, there's not enough of us. And I'm very involved in doing some training and education, and we're bringing out a new menopause education programme with a company called 14 Fish in the next few weeks, hopefully. So that will help. But you don't give up. If you're not getting the right advice, you should see another doctor or see a nurse. Sometimes the practice nurses are very good. You shouldn't have to go privately. A lot of us work privately because there's no care, there's not enough resources for menopause care in the NHS, which is beyond frustrating. Anyhow, if you're getting symptoms and side effects related to the progesterone, What you can do is change the way you take the progesterone. This is off license, which means it's not a licensed way of doing it, but research has shown that if a woman has progesterone vaginally, then it still protects the lining of the womb, which is what we need the progesterone for. And this can be done at half the dose. So, for example, if a woman was taking 1 capsule of Estrogen, the micronized progesterone, every evening, she can change and insert. So basically, you just shove the Estrogen up your vagina, and it's the 100 milligrams. So it's not the 200 milligrams, which is used for fertility. It's a 100 milligram, the same capsule that you use orally, you insert vaginally. You can't get it in the wrong place, you just insert it up. And it can be done at half the dose, so it means it's 1 capsule inserted alternate evenings. Or if a woman is having it cyclically, so orally 2 capsules for 2 out of 4 weeks, all you do is just do 1 capsule for 2 out of 4 weeks. So it's very easy. There is a type of pessary made out of progesterone called Cyclogest, which is used for fertility treatments. It comes as a 200 milligram pessary, and so what you can do is cut it in half. So a lot of women cut those in half and just use half. It's just got the natural progesterone in. Some people prefer it because it's made for the vagina, and some people get a bit of a residue if they use the capsule of the micronized progesterone, the oral capsule vaginally. So again, there's choices. So it's just trying to go through. Now, there are still some women who use it vaginally and still find they get side effects and find it very difficult to tolerate. And these women are more difficult to treat and manage, but sometimes we minimise the progesterone. Some of my patients only take it every 3 months, but then I arrange a scan regularly to check the lining of their womb. And there are some women who actually have a hysterectomy because they can't tolerate the progesterone. And this sounds really radical, but actually people have had hysterectomies for years because of heavy periods, and the heavy periods are only going to last till they're 50. But actually, we're going to often take HRT for a long period of time, so you're having an operation that in the future will last you. So, you know, there's options, so it's very important because it's usually the progestogen or the progesterone that limits HRT. So what are the side effects? Well, a lot of women get bleeding when they start HRT, and it's the commonest reason why people stop taking HRT. When women start their HRT, because it's stimulating the lining of the womb, then there's often increased turnover of the lining of the womb, so then there's more that can be lost, so there's a higher risk of bleeding. So for the first 3 months, we always warn people that you might get bleeding. Also, every time you change the dose of your HRT, then you might get some bleeding as well, so that's important. If you do get bleeding, don't be alarmed. You don't need to run off to your doctor to have a scan or tests. It will settle and it will be related to the HRT. If a woman has bleeding beyond 3 months, then there are other reasons sometimes why people can get bleeding, such as polyps or fibroids or other conditions. So it's important then to see someone to have some appropriate investigations, but you don't need to stop taking your HRT. A lot of women tell me that their doctors told them they have to stop taking their HRT because they've had bleeding. You don't need to stop until you know what's causing the bleeding. The other type of progestogen that people can often use really successfully is a Mirena coil. And now this contains synthetic progestogen, so not the body identical progestogen, but it's a very, very low dose, and it's a little coil that gets inserted in through the cervix into the womb, and it can last for 5 years. So once you have it in, it's for 5 years as the endometrial protection, so the progestogen part of HRT, and it's a contraceptive, because the other types of HRT are not a contraception. So if you need contraception, the Mirena is great. If you live in Scotland and you can't get the micronized progesterone, then Mirena is the next choice really. So ask for Mirena coil. Because of COVID, Mirena coils aren't being inserted at the moment, but it's something to think about post-COVID when we're allowed out and medical care goes back to normal a little bit more. So some people get a bit of breast tenderness when they start HRT, and that usually settles. Most side effects will settle within 3 months. A lot of people have asked about weight gain. Now, most people do not get weight gain taking HRT. In fact, a lot of women lose weight, partly because they start to feel better and they're exercising more, eating better, sleeping better. Because actually, did you know, women who don't sleep and men who don't sleep well have an increased risk of obesity and putting on weight. So if we sleep better, then that can help as well. Some people get fluid retention due to the progesterone, so changing the progesterone to a micronized progesterone often helps. Having the oral estrogen can lead to some fluid retention as well. So having it through the skin has actually been shown in some studies to reduce weight. A lot of women tend to put on weight in the midline during their perimenopause and menopause, and this is because our fat cells actually store some estrogen. So our body is saying, please, please give me some estrogen, and it is what it does is it stores the fat and doesn't let us get rid of our fat, and so we put on weight because our body wants estrogen. Actually, replacing the estrogen often helps to lose weight. Now, there are lots of benefits of taking HRT. One of them is if you get the dose and type right, your symptoms will improve, which is lovely, because then you're not crippled by all these symptoms which are having a negative impact on the quality of your life. But actually, I've already said there are all these health risks of the menopause. Well, we know from studies that when women take HRT, it reduces their future risk of diabetes, heart disease, osteoporosis. Even some studies have shown dementia as well. So this is really important to know. And this is the reason that a lot of women continue to take HRT. So a lot of women say, well, how do I know I've got through my menopause? When can I safely stop HRT? But actually you don't need to. The guidelines are very clear that we can continue taking HRT as long as the benefits outweigh the risks. And for most of us, the benefits do outweigh the risks because our symptoms improve, but more importantly, we have our long-term health benefits. So as many of you know, I take HRT, and I could stop my HRT today and find that I have no more symptoms, so I've gone through my menopausal symptoms, but actually as soon as I stop it, I'll have this increased risk of osteoporosis and heart disease, which I don't want. I actually am very scared about osteoporosis because I have seen so many patients who have osteoporosis of their spine, really disabled with it. You can imagine if you have osteoporosis of your spine and you're stooped, it affects your digestion. A lot of these people are in pain, they can't use their Zimmer frame, they can't get out of the bath, they're dependent on other people. So keeping my bones strong is one reason why I'm going to take HRT forever. But we can continue to take HRT forever. So it's very important that people know that. The study that showed this possible risk with breast cancer, which I'll mention in a minute, actually followed women up over 18 years and showed that women taking HRT have a lower risk of all causes, including from cancer. So lower risk of death from all diseases, including from cancer in women who take HRT. So that's really important to know. The big thing that people always worry about with HRT is this risk of breast cancer. So there's just a few things I'm going to tell you quickly about that. Firstly, if a woman's young, if she's under the age of 45, taking any type of HRT, there's no increased risk of breast cancer. So that's really reassuring. If a woman is older than 45, certainly older than 50, and has had a hysterectomy in the past and has estrogen-only HRT, there's no risk of breast cancer. So that's good. Then the others are people who have still got their womb, who are having a progesterone. We know the synthetic progestogens, there's a small increased risk of breast cancer. Now it's a very small risk, and to put it into context, a woman who's overweight or obese has a 10 times increased risk of breast cancer compared to a woman taking HRT. Or a woman who doesn't exercise, or a woman who drinks a couple of glasses of wine a night has an increased risk because they're risk factors for breast cancer. Taking the micronized progesterone, the Utrogestan, the risk doesn't seem to be there. Studies have shown the first 5 years there's no increased risk. After that time, the risk is lower than with the older types. And actually, you need to look at the bigger picture. So even if the risk of breast cancer increases a small amount, most women taking HRT feel better, so they exercise, they reduce their weight, they reduce their alcohol intake, so that other risk factors for breast cancer are reduced, even if their risk with taking HRT increases a little bit. So it's really important to look at the bigger picture. The Mirena coil and breast cancer risk, no data has been done, but we don't think there's an increased risk. So lots of reassuring facts there, hopefully, for you. So A lot of women are worried that they can't take HRT, and often that's because of misinformation. So, for example, if a woman has had a clot or a family history of clot, they can still take HRT, but they have to have the estrogen through the skin as a patch or gel. And if they need a progesterone, it has to be the micronized progesterone, because this does not carry a risk of clot. The older synthetic progesterones have a small increased risk of clot and heart disease actually, so they're best avoided by these women. If a woman has a family history of breast cancer or any other types of cancer, she can still have HRT, because actually it doesn't increase the risk further, so you can be reassured about that. Some people have asked, well, what about the contraceptive pill? Can I take that instead of HRT? Well, you can do, because it contains hormones, but actually they're synthetic hormones, so they're not body identical, and so they haven't got the same data which show that they reduce risk of heart disease and osteoporosis the same way as we do for HRT. So actually we don't advise first line having the contraceptive pill. Some young women like taking it instead of HRT, but we wouldn't recommend it. And then some people have asked about endometriosis. Can you have HRT if you have endometriosis? Yes, you can. If you've had surgery and it's all removed, then that's fine. You often only need estrogen. If you've got some endometriosis deposits left, then often we give progesterone as well to stop any ectopic endometrium being stimulated. If people have had thyroid disorders, often that can be more troublesome to actually their thyroid to be balanced before they have their HRT, and once they have HRT, then it's easier to control the thyroid. Having it through the skin is better, because tablet estrogen can affect thyroid sometimes. People with migraines can still take HRT, shouldn't have oral tablets because there's small risk of clot and stroke, whereas through the skin is absolutely fine, and migraines classically get worse during the perimenopause and menopause. So often we give patches because you have a constant level of estrogen. So migraines are fine. Women with heart problems, somebody asked me, they had a hole in the heart, absolutely fine. We know there's actually enough evidence to support the taking of HRT to reduce risk of future conditions. So even women who have very minimal symptoms can still benefit for their heart and their bone and their future health as well. A lot of people say they get turned away from HRT because they don't have enough or worse symptoms. Their GP says, you know, your symptoms aren't bad enough, or you're not getting hot flushes. We don't all have to have hot flushes to take HRT. So it's really important to push back and ask your GP why you're being denied HRT. On that subject, antidepressants are not a treatment for the perimenopause and menopause. They don't help the low mood associated with the menopause. A lot of women are inappropriately offered or given antidepressants. I hear it all the time in my clinic, on Instagram, and we did a survey of 3,000 women, and it showed that 77% had inappropriately been offered or given antidepressants. So antidepressants will help with clinical depression. They can sometimes help the hot flushes for women who can't take HRT in the first line. But if you have no contraindications and you're offered HRT, then that's what you should be offered, not antidepressants. So if a doctor talks about antidepressants, you need to say no, because the NICE guidance, the National Institute of Health and Care Excellence guidance, are very clear that antidepressants will not help the low mood associated with the perimenopause and menopause. So now, the other hormone that I'm going to touch on is testosterone, because there's been a lot of questions about testosterone, and I've already said we produce testosterone, and actually what I didn't know until a few years ago was that we produce more testosterone than estrogen from our ovaries. So when our ovaries are gone from an operation, or when they've stopped working, our testosterone levels reduce. Now, testosterone is very important in our brains, but also in our muscles, in our joints, in our skin, in our hair. Again, they get everywhere, these hormone receptors for testosterone as well as for estrogen. So the guidelines that we work out of, the NICE guidelines, are very clear that if a woman is taking HRT and her libido is reduced, then she can safely, or she can be offered testosterone. which all sounds really good and wonderful, doesn't it? But testosterone actually, really frustratingly, isn't licensed for women in the UK, which is incredibly frustrating. In fact, I don't think it's licensed for women worldwide, yet it's one of our essential hormones. And certainly behind the scenes, I'm doing quite a lot to try and change this, because we should be entitled to have our own hormone back, don't you think? There are different ways of having it in the UK. There are male testosterone preparations, because obviously men are allowed their hormone back, and that can be given in smaller doses. Now, the problem is with this is that it's very hard to get the dose right, and certainly I've seen a lot of women in my clinic who have tried sometimes their partner's testosterone, or they've managed to get it from their GP, and they've had very high levels, and the higher levels are more likely to cause side effects. So I would just be careful about what you use. In my clinic, we tend to use this, which I know some of you have seen because you've sent me photos, which is called Androfen, which is a female testosterone cream. It's not licensed in the UK yet, hopefully it will do, but it is regulated. So it's a regulated product that we're allowed under the MHRA to prescribe. It comes as a cream, it's a pea size, a very small amount that's rubbed onto the thigh every day. And we monitor levels. We do levels of testosterone and something called sex hormone binding globulin before starting treatment, and then we do it regularly afterwards as well. It's very important to have levels measured just to minimise the risk of side effects. So the problem also is that a lot of doctors and nurses are not trained in testosterone, and a lot of them wrongly think it's going to cause problems. And if it's prescribed properly, people are fine. It makes a huge difference to their mood, energy, concentration, as well as their libido. So obviously with part of the training we're doing, hopefully that will help. A lot of people get referred to a menopause specialist, and then they start the prescription. Some GPs will continue it if it's been started in a clinic. Some women, the only way they can get it is from a menopause specialist, sometimes only privately. The Androfen in the UK can only be prescribed privately. It works out about 80p a day, so it's not cheap, but it's not prohibitively expensive, and for a lot of women it can make a big difference, but you have to use it for usually between 4 and 6 months before knowing whether it's going to work for you. And most people find that it does help. It can help, especially with, like I say, mood, energy, concentration. It can help with muscle, joint pains. Sometimes it can help with some of the vaginal dryness symptoms as well. Mentioning vaginal dryness, I just want to spend a few minutes. This is so much information to take on board, but I hope you're finding it helpful. Please give me some feedback at the end and let me know whether it's worth me rabbiting on like this to you all. So with local estrogen is a treatment for vaginal dryness. So I'm sorry to talk about vaginas on a Sunday afternoon, but when we don't have estrogen in our vagina, the wall of the vagina becomes very thin. It becomes very inelastic. It becomes stiff. It has less blood supply, and so I've already said people have lots of symptoms. So we know that when you have HRT, that can help. But actually it doesn't help with everyone who's taking HRT, and there are some women who can't take HRT for various reasons or choose not to. So localized estrogen is very different to HRT. It only works locally in the vagina, and you can use it as a little pessary or some cream or a little vaginal tablet, or there's even a little vaginal ring that lasts for 3 months. Lots of choices. And what it does is it replaces the estrogen locally in the vagina, and then it makes the blood supply better into the vagina. It thickens the vagina, makes it more lubricated, makes it more elastic, more stretchy, so it's a lot better. It doesn't get absorbed into the body, and because it doesn't get absorbed into the body, it's very safe. So even women who have had breast cancer in the past, even women who've had estrogen receptor breast cancer in the past, can still usually safely use vaginal estrogen. It can also help with the urinary symptoms such as urinary incontinence, recurrent urinary tract infections as well. So that can be really useful. Now, I've got 5 minutes left, and then I think we get zoned out after an hour. I'm very conscious I haven't spoken about other treatments, and HRT is only one part of the menopause. There's no point me taking HRT and eating McDonald's and smoking 20 cigarettes a day and drinking alcohol. So we have to look after ourselves whether we take HRT or not, and we have to look at ways of improving our bone strength, reducing our risk of heart disease. So it's really important that we look at our exercise, we look at our diet, we look at our alcohol intake and our smoking. And then some women find that doing all that makes a huge difference. There are, like I say, some women who choose not to take HRT, and some women who've had an estrogen receptor cancer in the past can't take HRT in the first line. And I say in the first line because some of these women still can take HRT if they have the right advice from a menopause specialist in conjunction with a breast cancer doctor or other cancer doctor. So there are so many supplements in the market for menopause. Anything that's mentioned menopause I would avoid because they're expensive. There's a huge amount of advertising. Most weeks I get asked to have a name behind or quote behind one of these products, and I refuse. There's no evidence, so you have to be really careful what you take. All of us should be taking vitamin D, which is a sunlight vitamin, so that's very important. Men, women, we should all be taking vitamin D. There's a bit of evidence that folate, so folic acid, can reduce some of the vasomotor symptoms. Some people find sage helpful. Phytoestrogens are in a lot of supplements, but actually if you can't take estrogen, you probably shouldn't take a phytoestrogen either because it stimulates the estrogen receptors. Looking at ways of helping your bone strength, so making sure you have enough calcium in your diet is really important as well. And some people take things like a probiotic, fish oil. There's lots of things. Certainly, if any of you have listened to my podcasts, I've done quite a few. I've done a few now with Emma Ellis-Flint, our nutritionist, talking about diet. We talk a little bit about supplements as well. So it's worth looking at your gut health. It's really important. So just to go through the last few minutes, I just wanted to talk about some other resources. So as a lot of you know, I've got a website, it's called menopausedoctor.co.uk. If you go to the resources section there, I've got my podcasts are linked there. I've got booklets that are there as well. We've got lots of fact sheets, lots of information there that again is all evidence-based. I get no sponsorship for my website. It costs me a fortune. So, but there's lots there. We're constantly updating. So we've just put an article in there recently about starting HRT when you're older as well. So there's a lot of women who have been either stopped HRT or have never had it, and these women can often start HRT. Some of you might have seen my book. I know it's back to front, the Haynes Menopause Manual, which is available on Amazon. I've made it very easy to read. There's lots of pictures, lots of information. It is being translated into other languages, and it's also going to be an Audible version soon and on Kindle, which is very exciting. So there's that. Some of you might have seen this fabulous book by Jane Lewis called Me and My Menopausal Vagina, which is very good for any woman who's having menopausal symptoms. I would definitely recommend dipping into that because she writes very openly and brilliantly. Liz Earle, who a lot of you know, who has forced me to do this today, so it's her fault if you don't enjoy it. She's got an amazing Liz Earle Wellbeing website and podcast, and she's got her menopause book. She's got some great PDFs as well, so I would head over to her website as well. And then finally, some of you might have known, again, it's back to front, it's really annoying, isn't it, the phones. This says Balance. This is an app that we're developing. It's going to come out, it was supposed to be May, but I think it's going to be June because the main app developer is homeschooling his toddlers, so he doesn't have as much time as he thought he would have pre-COVID. So it's going to be free for all women. It's going to provide evidence-based menopause care globally for women. No mean feat, but there'll be areas to track symptoms. There's lots of information there, and there's a community, so all of you can join and share your experiences and what's helped. So I'm really hoping that's going to make a huge difference to people. We're really lucky that we've got some great support. We've got a fantastic team called Magnetic North who are working on that, so we'll let you know more about that nearer the time. So Hope that's been really helpful for you. I am super busy, so I don't always get time to read your direct messages, but if there is anything that you want, any more information, or if you want me to do another one or more focused on something, then I'm very happy to give an hour of my time. I will try and work out how to save this, so then we can put it on my website as well. So keep safe, all of you. I know it's really difficult times. Certainly I know I go from feeling fine to being super anxious and worried about everything, but we'll get there, and we've got to make the best of a bad situation. So take care. Thanks very much.